Hello, everyone, and welcome to tonight's webinar, the second in a series of 5 sleep webinars brought to you by the Capital Health Network and a multidisciplinary team of sleep physicians and sleep psychologists in the ACT. First, I would like to acknowledge the traditional custodians of the land we are meeting on today. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders past, present, and emerging. I also acknowledge and welcome any Aboriginal and Torres Strait Islander people who may be attending today's event. Their land was and has never been ceded. Tonight's webinar focuses on approaches to insomnia depending on patient age and stage. I'm Michaela DeLeva, a physiotherapist and Quality Improvement Project Officer at Capital Health Network. Also with me tonight is David Austin, psychologist, and Dr. Ting, sleep physician, and of course, Kanal Mohiti, the events lead at Capital Health Network. Just going to run through a little bit of housekeeping. So all participants tonight have been muted. Please address any questions that you might have in the Q&A section, not in the chat box of the side panel of your Zoom window. And then at the end, we will have a question and answer session after both David and Dr. Ting have finished presenting. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you are welcome to share this with your networks. In regards to CPD, please fill in the post-event evaluation survey, which CHN will email you a certificate of attendance after the event. And please feel free to self-report 1.5 hours of educational activities to your CPD home. Before we start, I would just like to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including insomnia and other sleep disorders. The login is together and the password is forhealth, one word, all lowercase. Health Pathways are a reliable source of up-to-date clinical and referral information that is localized to the current area. Your feedback is invaluable to keep the pathways updated and reflective of the local health environment. You will find a feedback tab at the bottom of every pathway, and your feedback is most welcomed. Our first speaker for tonight is Dr. St. Trence Ting. Terry is a specialist in respiratory and sleep medicine. After graduating at the Faculty of Medicine at the University of Edinburgh, UK in 2006, Terry relocated to Australia in 2008 and embarked on physician training at the Canberra Hospital and Health Services. He went on to complete his specialist respiratory and sleep medicine training in Canberra and Sydney's Liverpool and Westmead hospitals. Terry is the director of ACT Lung and Sleep, located at Calvary Clinic in Bruce, and co-director of RESP ACT Lung Function Testing Laboratory. Terry is a consultant physician at the North Canberra Hospital, formerly Calvary Public Hospital, and has admitting rights at most private hospitals in the ACT. In addition to clinical medicine, Terry is also an accredited local examiner and educational supervisor for the Royal Australasian College of Physicians. And in his spare time, Terry enjoys training in karate, traveling with his family, as well as listening to both jazz and classical music. So I'll now hand over Terry to start his presentation.
Great. Thank you, Michaela, for the kind introduction. Okay. All right. I hope you can still hear me and see the screen. Excellent. Great. I haven't slept for months, Doc. I think a lot of us had been asked about this, or a lot of patients mentioning about this in our clinic. So insomnia is incredibly common. In fact, is one of the most common presenting sleep problems. So let me introduce Jane. She's a 25-year-old lawyer. And when I first met her, she told me, she's never been a good sleeper ever since she was a teenager. Her sleep hygiene was otherwise reasonable, and she's very intelligent, and she's already looked into this condition and did some of her own research. By the time she saw me, her bedtime had already sensibly been delayed to around 11 p.m. to around midnight. The estimated sleep onset latency, however, continued to be prolonged at around 3 hours. Just like a lot of the chronic diseases, the symptoms varied and became in waves, sometimes a bit better and sometimes a bit more severe, but on and off, for a number of years now. Once she has managed to fall asleep, she denied any obvious sleep apnea symptoms. In other words, she denied any history of witnessed apnea events or history of loud and disruptive snoring. Subjectively, she feels that her sleep was rather consolidated. Usually, her alarm is set at just before 7:10, and she hits the snooze function a few times, and the final alarm is usually set around 7:30 in the morning. But when she gets up, she doesn't feel refreshed. She complained of a lot of excessive daytime fatigue and lethargy, but not particularly sleepy. In other words, she was not hypersomnolent. And that was reflected in her Epworth sleepiness score as well. And I'm sure a lot of us are quite familiar with this. And it was rather low. It scored a 5 out of 24. And the other questionnaire score, which was the stop band questionnaire score, was also negative. It was only 1/8. Just a quick recap. I'm sure you're quite familiar with this. It was discovered or basically founded at the Epworth Hospital in around 1990. Basically, you provide a patient with a set of hypothetical scenarios, and you ask them what are the chances of them falling asleep. They need to fill in the questionnaire themselves, and their responses will be no chance, slight, moderate, or high. So as you can see here, Jane scored rather low. She answered no or 0 to a lot of the scenarios, but only slightly, feeling slightly sleepy when she read and sat down, and also slightly sleepy when she was sitting quietly after lunch without alcohol on board. On the other hand, when she had a chance or circumstances allowed, she was sitting in the passenger seat in a road trip in the car for an hour or so without a break. It's a high chance that she would fall asleep, and she scored 3 on that one. So altogether, it was 5 out of 24. Stop band questionnaire score is another set of questionnaires to look for clues and symptoms and features of sleep apnea. It's an acronym, STOP and BANG. S stands for snore, snoring loudly. Do they feel tired or fatigued? Were there any observed pauses in the breathing or symptoms of them choking or gasping for breath? Was there a history of high blood pressure that has been treated by medications? Was their BMI greater than 35? Was the age greater than 50? We also asked them or measured their neck size as well. The gender was also important. They scored 1 point if they were male. So in Jane's scenario, she only scored 1, as she felt often fatigued and lethargic during the day. When it comes to driving, she felt that she's been performing driving very well. She felt alert and felt confident behind the wheel. There was no history of motor vehicle accidents. But there was one isolated incident whereby she found herself driving on the wrong side of the road. That was a split of a second, and she quickly steered back onto her lane. Otherwise, there was no frequent naps or snoozes in the afternoon. Her caffeine intake was quite low, only 1 cup of brewed coffee. Alcohol consumption was also minimal. Her sleep hygiene was quite good. I thought it was reasonable. She usually puts away most electronic devices and stops screen time about 3 to 4 hours before going to bed. But she reads a Kindle in bed and usually puts this away when she feels sleepy. She's been taking slow-release melatonin. I think a lot of us are quite familiar with this medication. That has been previously trialed, but she did not experience any significant improvements in her symptoms. Sometimes on the weekend or day off, she would just catch up with her sleep, and sometimes sleeping for 10 hours, but still getting up in the morning, not feeling refreshed. It kind of made me ponder whether her sleep quality was actually compromised. In particular, I was suspecting whether she had any features of sleep apnea. In terms of family history, there was a brother who was recently diagnosed with ADHD when I saw her, and she wondered whether there was a connection there. She also suspected herself as being neurodiverse, and she wondered whether she had undiagnosed ADD. Otherwise, there was no family history of sleep disorders, in particular, no family history of sleep apnea. And on physical examination, she was a little overweight, but not in the obese category. Her oropharynx was a bit crowded, with a modified Mullen-Parley score of 3. She was saturating on room air quite well, 98%, no signs of respiratory failure or chronic lung diseases, no signs of cardiac diseases or valvular heart disorder. Her chest was completely clear and she had a normal neck circumference. A lot of us are most likely familiar with modified Mullen-Parley score. It's a physical examination classification of how crowded our oropharynx is. And it comes in four different classes, class 1 to 4. Hope you can see my cursor here. So class 1, whereby all the components were all visible, including the soft palate, the oropharynx or the opening of the oropharynx or the fauces, the tonsillar pillars, as well as the uvula. Whereby class 2, you can't really see the tonsillar pillars there. Class 3, the only visible parts were the soft palates and also the base of the uvula. Whereas class 4 Mullen-Parley score, even the soft palate was invisible. You can only see the hard palate. So my initial impression was that Jane presented with predominantly chronic sleep initiation insomnia, but I would like to exclude sleep apnea. We talked a bit further about how to perfect or optimize her sleep hygiene even further, and I introduced about sleep stimulus control. I asked her to delay her bedtime to a little bit later, to 20 past 11, and to minimize her time in bed. I also prescribed her with lemborexin as an orexin receptor antagonist, to be taken about 20 minutes before going to bed. And I explained to her that if she was unable to initiate sleep, instead of just laying in bed and tossing and turning, having lots of negative thoughts turning through, maybe it's better to just get out of bed and get out of the bedroom, to break that cycle and to engage in some sleep promoting activities, whatever she enjoyed, but nothing too mind-boggling. For example, reading a boring book, listening to some calming or relaxing music, even meditation, etc. And then returning to bed only when she feels sleepy again. She should continue to wake up early, at around 7 a.m. is fine, and that sleep-wake pattern should remain constant throughout the entire week. And unfortunately, no more luxury of sleeping in on the weekend or day off. When she gets up, just undo the blinds and open up the curtains, and she should have adequate exposure to daylight and preferably some exercises outdoors. As I said, I would like to exclude an underlying obstructive sleep apnea, and I arranged a diagnostic sleep study. Can you see this okay? It looks a bit busy. I hope it projects quite well on the screen. You can see this? Okay. Excellent, got a thumbs up. So why don't we look at this grammatic, sort of diagrammatic or graphic illustration, like a summary of that diagnostic sleep study first. And we'll go through that briefly. So the study date, and you've got the time here. So recorded the time. Lights out was approximately 10:30. Now you can see that it took Jane some time to actually fall asleep. The first stage of sleep, transitional sleep or stage 1 sleep, was only recorded about 12:15 or so. So she spent a lot of time in bed to get comfortable to begin with. But after sleep onset was achieved, as you can see here in the hypnogram, the sleep stages were rather solid. The architecture was rather solid. There perhaps had been some breaks and some fragmentations in between, but the overall picture was quite solid. We also recorded or measured the positioning of the patient whilst they were having the sleep study. She spent most time either on her right-hand side and also on her back. But she also spent a little bit of time on her left-hand side as well. This is the SpO2 trace. It's pretty self-explanatory. As you can see, it's a beautiful, nice flat line. Close to 100%, but certainly between 90 to 100%, so reasonably normal. And here were the recordings of the sleep apnea events. So the patient turned up to a home diagnostic sleep study. They get wired up. They have lots of dots and electrodes on them, measuring their brainwave activities, the EEG, measuring the flow of air through the nostrils, the nasal airflow monitoring, and also a couple of bands measuring the so-called respiratory effort, measuring the movements of the chest and the abdomen. By measuring these parameters, we can tell whether the patient is suffering from apnea episodes or hypopnea episodes, whether these episodes were resulting in limitation in airflow, reduction in respiratory effort, and also oxygen desaturation, with or without association with awakening from sleep or arousal. And you can see here, there were some sort of infrequent intermittent events, but the overall picture was rather unremarkable. There were no recordings of any apnea events, but a few sort of minor partial narrowing of the upper airway hypopneas. We also recorded some snoring as well, intermittently. Here, with a bit more detail, you have some numbers. I think it's quite important in this scenario to pay attention to sleep architecture. We can see that the total recording time was over 500 minutes. The total sleep time was about 7 hours. The sleep efficiency is a measurement of how much sleep we actually recorded over the available sleep time. So the numerator is the total sleep recorded, and the denominator would be the time in bed. In her scenario, was a little bit reduced. Normally should be should be 85% or higher. In her scenario, was mildly reduced to just under 79%. And as you can see here, there was no significant sleep apnea. When it comes to the diagnosis of sleep apnea, the cutoff for mild sleep apnea would be 5 events per hour or more. And the cutoff for moderate would be 15 per hour or more. And when it comes to severe, would be 30 times per hour or higher. So her AHI was actually within the normal limits. And you can see it was across the board as well. Perhaps slightly high in REM stage sleep, but not particularly significantly so. And in the supine position also was within the normal limits. Here, as you can see, okay, I hope you can see the cursor. The average nocturnal SpO2 was normal, 95%. And even at the lowest point, the minimum SpO2 recorded was only borderline low, 92%. The oxygen desaturation index is self-explanatory. It's a recording of how often the patient had a drop in the oxygen saturation by 3% or more. That was normal, 0.3 per hour. So sleep apnea was excluded. We had some objective measurement of her sleep architecture. And now we'd like to move on to focus on her insomnia management. So I saw her a couple of months later after the initial consultation, and I explained to her that diagnostic sleep study pretty much excluded any significant obstructive sleep apnea. She had been adhering to my advice and suggestions, and thankfully her sleep onset latency has significantly reduced. Her wakefulness after sleep onset also remained rather low. However, unfortunately, she experienced side effects in relation to the use of lemborexant. She experienced sleep paralysis since she started on treatment. This was the first patient who experienced these side effects in my cohort. And looking up at MIMS, in addition to obviously feeling oversedated, hypersomnolence, headaches, vivid dreams, etc., sleep paralysis is also reported as an adverse reaction. So I've reduced the dose to 5 milligram Noctane instead of 10 milligram. I saw her again shortly after. The lower dose of lemborexant was very well tolerated. The bedtime has been delayed to 11:30. She tends to read in bed and lies out at around midnight. The sleep onset latency remained very short, and sleep remained pretty solid and she routinely gets up in the morning at around 7 a.m. Thankfully, she had been feeling pretty refreshing. She also denied any excessive daytime fatigue or hypersomnolence. Her ability to remain focused and to concentrate had been well preserved. She rarely consumed any caffeine or alcohol, and I was planning to see her again in 3 months. Okay, we'll probably leave the Q&A towards the end. So I would like to provide our audience with a bit of an overview of insomnia. As I mentioned before, insomnia is in fact the most common sleep disorder. Obstructive sleep apnea is actually second. There was one study or survey done that 1 in 3 Australians experience at least episode of mild insomnia at any given time. The prevalence increases with age, being more common in female, and sometimes, as we know, can coexist with a range of medical or mental disorder, particularly neurological, physical illnesses, as well as other sleep disorders. We often categorize insomnia into short-term, sometimes also called acute or adjustment insomnia, whereby symptoms usually last for a few days or weeks. There are occasionally identifiable stressors, and symptoms should be less than 3 months altogether. Those stressors can be physical, psychological, psychosocial, or interpersonal. Whereas chronic insomnia is defined as having insomnia symptoms lasting for at least 3 times per week and persisted for at least 3 months. I think it is worthwhile to spend a little bit of time on the diagnostic criteria. The International Classification of Sleep Disorder actually set out some useful information if one would like to be specific and to confirm the diagnosis of insomnia. There are 6 criteria that should be met. And first of all, criteria A. The patient would report, or the patient parents or carer will observe one or more of the following: difficulty initiating sleep, maintaining sleep, getting up earlier than desired, resistance to going to bed at an appropriate schedule, finding it difficult to sleep without the parent or carer or the carer presence or intervention. The patients would experience one or more of the following symptoms, such as fatigue, malaise, impaired attention, concentration, memory, impaired social, occupational, or academic performance, mood disturbances, etc. Also, the patient will report sleep-wake complaints that cannot be entirely explained by inadequate sleep opportunity. Then that's quite important, and we'll come back to that later on as well. There would be sleep disturbances and associated with sleep symptoms or daytime fatigue symptoms occur, as I mentioned, at least 3 times per week. Those symptoms may be present for at least 3 months, and these symptoms are not solely caused by either concurrent sleep disorder or medical condition. Now, not all poor sleep manifestations are due to insomnia. I think it's important to at least consider other differential diagnoses, such as just being sleep deprived and not getting enough sleep opportunities. They have short sleep duration. That goes hand in hand with chronic sleep efficiency. Whether the patient has underlying circadian sleep-wake disorder, either delayed or advanced sleep phase disorder, or whether they suffer from shift work sleep disorder, which applies to a lot of us, having been working in the healthcare industry for some time. Other conditions would be restless leg syndrome, as well as sleep disorder breathing, encompassing obstructive or central sleep apnea, or other form of sleep disorders relating to breathing difficulties, such as underlying respiratory failure, coexisting with other chronic lung diseases. As we know, in different age groups, our requirements or sleep duration will be quite different. For example, for my primary school kids at home, I would prefer them to have between 9 to 11 hours of sleep, but they're clearly short of that, probably in the region of 7 hours or 8 hours during the night. But as we get older, as we know, that it could be as short as 5 to 6 hours, even though the recommended hours would be between 7 to 8 hours. So what I'm trying to say that it varies depending on the age group. As I mentioned before, I think it's quite important to try to find out a distinction between insufficient sleep or an underlying insomnia disorder. One key sort of factor would be for those patients who have been sleep deprived, once they're given plenty of opportunity to sleep, they're actually able to sleep. Whereas patients suffering from chronic insomnia is often very disrupted, and they cannot sleep even when there were plenty of opportunities to get sufficient sleep during the night. Circadian rhythm sleep-wake disorder is not rare, often classified into or categorized into delayed or advanced sleep-wake phase. The delayed sleep-wake phase disorder is in fact one of the most commonly revised differential diagnosis of insomnia. I'm sure we share a lot of patients with similar problems. They're often more common in younger adults or adolescents. They sometimes self-describe themselves as so-called night owls. And I think that's quite important to distinguish this condition from sleep onset insomnia. Advanced sleep-wake phase disorder is the reverse. More common in older individuals. Often they are pretty sleepy and ready to go to bed by 7 p.m. And they get up incredibly early, sometimes between 3 o'clock to 4 o'clock in the morning. I think asking the patient to keep a sleep diary or using a tachygraphy device, or these days wearing a smartwatch may help. I touched on restless leg syndrome and also the common sleep disorder breathing. Restless leg syndrome is, again, not rare. I think a lot of us have patients suffering from this condition. Often patients would describe as incredibly unpleasant sensation, sometimes described as hands crawling up the legs or pins and needles. Is a pretty restless feeling. It is often worse during inactivity or they're resting, maybe worse in the evening or at night. But sometimes patients get daytime symptoms too. It is often relieved by movements such as getting up, walking, stretching the legs. It's important to make sure that it's not due to other medical conditions, such as leg edema, fluid overload, myalgia, leg cramps, arthritis. And I think it's incredibly important to look at their kidney function and to exclude iron deficiency anemia. The International RLS rating scale can often be helpful to confirm the diagnosis and to ascertain the severity of the disease as well. Sleep apnea is incredibly common. As I mentioned before, it's the second most common sleep disorder after insomnia. Often patients feel the sleep is pretty fragmented. They had a lot of frequent awakenings purely because of a biological problem. They were having hypoxia events during the night. Their bed partners or family members, or even people they traveled with, sometimes would be friends or relatives, would report a long-standing history of loud and disruptive snoring, sometimes associated with witnessed pauses in the breathing, with or without sensation of choking or gasping for air. They feel incredibly unrefreshing when they wake up, occasionally associated with morning headaches, but quite often daytime fatigue and hypersomnolence. As we all know, it can be associated with a wide range of medical conditions, predominantly affecting the cardiovascular and the cerebral vascular health. It can be associated with metabolic syndrome, respiratory diseases, mental health disorders, and more recently, some emerging evidence to suggest a link between sleep apnea and early onset dementia as well. Obstructive sleep apnea and insomnia can coexist, or so-called comorbid insomnia and sleep apnea, or COMISA. It's been reported around 15% of insomnia patients actually suffer from moderate to severe sleep apnea. Okay, I'm not going to bore you with all the detail, but there's a good sort of, basically this slide is to show that it's important to look at different differential diagnosis. And just like diagnosing a lot of chronic health diseases, the key is in the clinical history. And all those tests and the investigations at the disposal of our fingertips, it's just to guide us to confirm the diagnosis and to ascertain the severity. So the key is actually in the history. For example, if the patient tells you that they find it really difficult to get into sleep, and then the follow-up question might be, you ask them, so do your legs bother you when you actually sit down or lay in bed? If so, then you need to think about restless leg syndrome. Similarly, if the patient complains of finding it difficult to remain asleep and they wake up feeling incredibly tired and sleepy, that kind of make you ponder, do they actually have sleep apnea? Is the sleep quality itself is being affected because of pauses in the breathing and associated with nocturnal hypoxia? When they complain to you or stated that they actually wake up feeling, they wake up in the early hours in the morning, just by 3 o'clock or 4 o'clock in the morning, just being wide awake. You might want to ask, do they have any hidden depressive symptoms? Okay. So this is just a reminder that the sort of etiology and try to conceptualize the pathology of chronic insomnia. There's often some predisposing factors, which can be genetics, congenital, or related to family history. There may be precipitating events. For example, a severe and unfortunate accident leading to physical injury, where there have been some severe psychosocial stressor in life, such as separation from a spouse or a bereavement in the family, or even financial difficulties, particularly applicable in the current economic sort of climate and with the cost of living, ramping up. I think it's important to ask about, is there any serious change in their financial status? Are they going through a lot of financial stresses, changed occupation, loss of job, for example? Sometimes there are perpetuating factors, something that you really can't change, and maybe develop some suboptimal lifestyle habits that continue to perpetuate the symptoms of insomnia. I'm not going to dwell on too much about the cognitive behavioral therapy aspect of insomnia. I've got David here, who's an expert in this area, but I'm just going to give you an overview about the treatment of chronic insomnia in adults. Broadly speaking, we can categorize them into CBTI, or cognitive behavioral therapy, specifically designed to treat insomnia, as well as historically pharmacotherapy. Okay, so very briefly, CBTI is the first line, it's the gold standard. Ample amount of evidence is proven to be effective. Usually the efficacy is more long-term and more robust. Lots of long-term outcome studies demonstrate superior efficacy over medication alone. Often in clinical practice, the combination approach may be better because you can actually get a quicker response and perhaps you get a better outcome quickly, so that the patient may adhere to your advice and management plan a little bit better. The combination approach is often faster, but there's often an important plan to actually taper off the medications concurrently. CBTI basically focusing on the cognition, the thoughts, for example, and the behavior that might interfere with good sleep hygiene or sleep-wake pattern. Historically, face-to-face sessions will be preferred over 4 to 8 sessions, but commonly these days, and the pandemic has probably done some good. I continue to provide telehealth in my practice consultation, particularly for patients who live afar outside of Canberra region. So we can utilize that, and sometimes patients may wish to continue with the telehealth consultation with the service provider. There are some sort of online self-help programs as well. I believe the NHS in the UK would provide sponsor and funding for individuals to go through all those online programs, such as the Sleep Hero program, which has been quite commonly utilized in the UK, and they were not found to be inferior. In terms of the cognitive approach, is usually address the anxious and the catastrophic thoughts associated with sleepiness. Any inappropriate expectation about the hours of sleep, and try to correct the misconception or perception of a string of adverse events or a string of unfortunate events are caused solely by the fact that they had not been sleeping well the night before, which may not be true. But sometimes patients may have this sort of distorted thoughts, perhaps. The psychologist may also go through some relaxation techniques, mindfulness techniques, etc. It may be a bit slower, but often more substantial and sustained improvement in the longer term. On the other hand, the behavioral approaches may focus on their sleep or time restriction in bed, stimulus control, a good sleep hygiene, etc. It can be challenging at times, however. It is also very important to identify any particular causes to perpetuate the patient's presenting symptoms. For example, any underlying anxiety disorder. The outcome usually is measured in terms of reduction in the time for them to fall asleep and also their ability to maintain sleep. In terms of objective measurements, sleep diary would be incredibly helpful, as well as the objective measurement of insomnia severity index. I attended a conference about a couple of years ago in Brisbane, and I attended a seminar during that conference about the challenges that a lot of the healthcare providers, whether it's clinical psychologists, GPs, or sleep physicians alike, about CBTI. Unfortunately, we're only treating a tip of an iceberg. Okay, not many patients suffering from long-term insomnia we actually seek help. We just thought, okay, this part of it. You know, very often I see a patient and introducing myself and ask them what the presenting problems were. And, you know, clearly the referral is chronic insomnia. And I asked the patient, so how long have you not been sleeping well for? And sometimes they say, well, 40 years. So sometimes my heart would just sink. You know, it's not going to take 40 days to actually turn this around. So not a lot of patients will actually seek medical attention, and only less than 10% of those patients who actually sought help will be referred to undergo CBTI, and of which only about 70% of those patients will actually start treatment. Yeah, and as you can see, go on there, and about 40% of patients who started on CBTI will eventually drop up, and only about 2% of patients then complete treatment. And the remission rate may be better now, but it had been quoted to be as low as 40%, but it's all very individualized. Sometimes the success rate would be a lot higher too. It varies. I went to the CHEST conference, and I think Dr. Carol Huang was amongst the audience today in our seminar. And she was there, and this photo was taken by myself on the infamous Diamond Head, which is a dormant volcano, as we know, in Honolulu. There was a CHEST conference in Hawaii last year. Incredibly enjoyable, and I brought my family to tag along. But obviously, it was work-related. That's the Hanamua Bay, I think it was. Correct me if I'm wrong, it's incredibly beautiful. Look at all these coral reefs there. It's a stunning, beautiful day too. And as I said, it was a work-related event. I assure you that. I learned a lot of good stuff. Okay, to continue. So I learned about 5 components of CBTI. So first of all, it's about sleep consolidation and restriction. I'm mindful of time, so I'm not going to draw in too much about the details. Secondly, is about stimulus control. For example, only go to bed when the patient feels sleepy, and only reserve the time in bed for sleep and other intimate activities. But as I mentioned before, the patient can't fall asleep at all. Don't look at the clock, take away the clock, but just an estimation. If they couldn't fall asleep by 20 minutes or so, I often ask them, do yourself a favor, please don't stay in bed. Just get out of bed, get out of the bedroom, and engage in some sleep-promoting activities, and only return to the bed when you feel sleepy. As I mentioned before, the sleep-wake cycle should remain unchanged, and there shouldn't be any nap. The therapist will often discuss with them about relaxation techniques and improving their cognition and behavior, and that comes with the cognitive therapy component. Okay, I'll let David tell a bit more about that later on. Now, good sleep hygiene, we all hear about that. We all tell it to our patients. Basically, it's pretty self-explanatory. All the good things that our mothers asked us to do and not to do when we were children. Okay, for example, regular bed and rise time, avoid napping during the day, limiting caffeine, alcohol consumption, avoiding nicotine, exercise regularly. Okay, so making sure the sleep environment is quiet, it's dark, they feel safe in the environment. Put away the alarm clock or the digital clock next to them, and avoid late, heavy evening meals. But at the same time, don't go to bed empty stomach either. Okay, so without knowing how, or grasping some basic understanding about circadian rhythm, is difficult to conceptualize the treatment of or pharmacotherapy rather of insomnia. Circadian rhythm. So living organisms, human included, had long been exposed to rhythm changes in the environment, be it the Earth rotation, its movement around the sun, gravitational effect of the moon, etc. Circadian came from the Latin term circa diem, basically meaning about a day, referring to the biological variations or rhythms with a cycle of approximately 24 hours. But as we know, it's actually not 24 hours. It's more like about 24 hours and 11 minutes, give or take about 15 minutes. The circadian rhythm is endogenously generated in the absence of external input, but can be affected by external cues. It is not just simply a passive reaction of the daily cycles in the environment. Zeitgeber, German term, a German name for time giver, basically referring to external time cues that synchronize our circadian rhythms. Now, environmental light is sunset now. Environmental light is actually primary zyge. Light exposure is therefore able to adjust or realign our circadian rhythm by shifting the phase of our endogenous body clock. Light with short wavelength, the smartphone, for example, causes greater shifts in the circadian phase and can contribute to insomnia symptoms, as we all know. Okay, and where's the circadian clock in our body, in mammals at least? Is anterior to the hypothalamus in our brain, in the so-called suprachiasmatic nuclei, or SCN. It is sitting directly above the optic chiasm. It regulates melatonin secretion, which is endogenously produced. Sleep-promoting hormone, as we all know, is produced and secreted by the pineal gland in our brain. It is present in both nocturnal and diurnal animals, and sometimes melatonin is coined the hormone of darkness as a result. Okay, very basic pathophysiology. We have the ganglion cells receptor at the back of our eye, the retina, which receives darkness and light. When we see light, it sends signals to the suprachiasmatic nuclei through the retinal hypothalamus tract. Now, when it hits the SCN, the sort of intrinsic activity is to inhibit the paraventral nuclei. But in the absence of light, in other words, in darkness, that these nuclei can get activated and then sending signals to the superior cervical ganglia in the brainstem, which in turn sends signals to the pineal gland and secrete melatonin, which then is released in the CSF, the cerebrospinal fluid, into our bloodstream as well. Eventually, it gets metabolized and excreted in the urine through the kidneys. Okay, so intuitively, synthetic melatonin and melatonin receptor agonists can therefore increase the serum level of melatonin. It is particularly helpful in treating patients who've been suffering from disruption of circadian phase, contributing to insomnia symptoms. The most commonly available or prescribed medication in Australia would be Circadin, or slow-release melatonin, often at 2 milligrams in the evening. It is important that it is best taken 2 to 4 hours before bedtime, and the patient should continue with medication for weeks because it takes a number of weeks to actually kick in. Now, I'm not aware of melatonin receptor agonists being available in Australia, but I understand that it is available elsewhere in Europe and the US. The brand name of Rameltion. The Z drugs, such as zolpidem, commonly known as Stilnox, or zopiclone, commonly known as Imovane. These are the so-called Z drugs or benzodiazepine receptor agonists. Probably they have a low risk of dependence, maybe better tolerated than good old benzo. I rarely prescribe benzodiazepine these days, unless when I do my public hospital inpatient service, looking after inpatients in acute setting, in intensive care, in critical care, and with acute medical illness, the very noisy, busy environment, then I may prescribe, if necessary, low doses of such as temazepam, etc., to help them to get some hours of sleep during the night. In terms of zolpidem or zopiclone, Stilnox and Imovane, etc., previously it had attracted some sort of publicity about the association with parasomnia symptoms such as sleepwalking or other rather unusual sleep behaviors. But in practice, I don't see that very often, but it's clearly well described previously. Maybe it's better tolerated with patients with sleep apnea. It does not have that sort of degree of muscle relaxation effect when compared with benzodiazepine. So maybe it's a better choice in patients who suffer from OSA. More recently, I think it's available for the last 6-7 years or so, would be the orexin receptor antagonists, commonly known as Belsomra or Dayvigo, suvorexant or lamborexant, respectively. These are the so-called new class of medication that blocks both orexin 1 and orexin 2 receptors. So these are sort of these receptors, and orexin themselves is wake-promoting neurotransmitters, and intuitively, if you block those receptors, you would promote sleep. And it's often quite helpful when it comes to promoting sleep initiation and maybe maintaining sleep after sleep onset as well. Generally speaking, is pretty well tolerated. Common side effects may be oversedation, grogginess, bit of headache in the morning, rarely sleep paralysis. But in Jane's case, as you can see, she actually experienced that. But thankfully, symptoms completely resolved after reducing to a lower dose. Historically, other commonly prescribed medications, and I think some of us have even taken them before as well, would be antihistamine. These are lousy antihistamine in the sense that they're not very good at providing the sort of mitigating the allergies and the hay fever symptoms, but very good at making the patient drowsy. So things like Phenergan and Restorfit and things like that. But often the side effects can be a bit of a problem, and the effects tend to wear off after a few weeks. Now, those patients who have underlying anxiety, depression symptoms, maybe we can try other medications to control the both sort of aspects of the symptoms, such as NDEP, which is a tricyclic antidepressant with its sedative properties. Avanza, mirtazapine, I've certainly prescribed on a few occasions, particularly when the patient also presents with concurrent depressive symptoms. I think the sort of sedative effect was mainly coming from the H1 antagonist component rather than the antidepressant component. Valdoxane has been quite commonly prescribed these days as well, or agomelatine is a combined melatonin receptor agonist and also 5-HT2 antagonist. It provides the patient with alleviating anxiety disorder symptoms and maybe promoting sleep and advancing the circadian rhythm as well. Okay. Well, it's almost 45 minutes on the dot, so I think I'll just stop there. There are some sort of useful information. The Australian Sleep Health Foundation provides generalist, whether it's general physicians, GPs, or any healthcare professionals who look after patients with sleep disorder would be more than welcome to get some useful information, and they provide patients with some useful patient information leaflets as well. Up to date is also, as always, a good source of information. And also there's a textbook there, which is quite interesting and easy to read. And it gives you an overview about sleep medicine. And it's written by Mansfield and his colleagues. And it was published in Melbourne a few years ago. It's an Australian textbook with a lot of the local experts in the area contributing to this textbook. It's quite easy to read and it's quite fun to read as well. Okay, so I'll stop there.
Thank you, Terry, for a fantastic presentation there. We'll come back to questions right at the end. So now I'll introduce our second speaker of the night, which is David Austin. David has been a psychologist in Canberra for over 20 years, working in diverse areas, including primary and secondary education settings, including disability education, occupational rehab, family dispute resolution, and child protection. He currently works part-time at Psych Sessions, providing in-person and telehealth therapy. Although fascinated by all aspects of the working of the mind, David has a long-standing interest in helping people with anxiety, trauma, or attachment challenges. Sleep and insomnia are a relatively recent professional focus, and he is especially envious of those who can remain cheerful and capable after less than 8.5 hours of sleep. So David, I'll now pass on over to you to start your presentation.
Thanks, Michaela. Hopefully people will be able to see that screen. Terry has covered in brief some of the aspects of psychological treatment. I'm hoping to go into a little more depth without providing a full instruction on delivery of therapy for insomnia, mainly to support effective multidisciplinary collaboration and effective referrals and continuity of care. I'm hoping that I'll be able to offer you some information to increase your confidence in discussing this option with your patients. I won't be addressing parasomnias such as restless leg syndrome, hypersomnolence, or the treatment of comorbidities, things like pain syndromes. I will try and make time so that I can briefly discuss circadian rhythm, sleep-wake disorders that Terry mentioned. You'll notice that the screen is orange. Hopefully that fits with the idea of we're phasing into the last of the day and we're reducing the amount of blue light. And I can keep it interesting enough that you don't slip into sleep.
David, we're not able to see your screen.
What are you seeing?
You.
That's really tricky. Let's see whether I can share, because I don't get any of your picture. Slide, no slides? Nope.
Slides. We've got slides now.
Okay. Cool. Thank you. So at least 3 definitions out there of insomnia. The common point that I would note is the requirement for the presence of daytime impairment. That includes the ICSD that Terry mentioned, the World Health Organization's ICD-11, and the Diagnostic and Statistical Manual from the American Psychiatric Association. In all of these, terms such as acute insomnia, stress-related, transient, primary or secondary insomnia have all been dropped. They're no longer in current diagnostic use. Also, perhaps of interest in the DSM's summary of the situation, they have a strong element of subjectivity, the distress or impairment criterion. And I'll talk about that in a little more detail. The working group on the DSM actually said, and I quote, findings, this was regarding HPA axis activation, are consistent with the hypothesis that increased physiological and cognitive arousal plays a significant role in insomnia disorder. My take on that is effectively, if you're awake, you're not asleep. More helpfully, though, I think if we can support our patients to reduce physiological and cognitive arousal, sleep is more likely. I'll be discussing the dot point on coexisting disorders a little more later. So, as Terry mentioned, disordered sleep is pervasive. Another study finding that up to 15% of adults met criteria for insomnia. The subjective element, for instance, on the DSM, arbitrary and illustrative, their words not mine, diagnostic guidelines include subjective sleep latency of more than 20 to 30 minutes, a subjective time awake of more than 20 to 30 minutes, and waking at least 1 hour before scheduled time and before total sleep time of 6.5 hours. They did describe them as arbitrary, and often we will be led by the experience of distress that the patient presents. Unlike things like obstructive sleep apnea and oxygen saturation, where you have a very clear set of cutoffs, insomnia has a strong subjective element. And many of you will have probably had an air of desperation from clients around, this is my last shot, I've tried everything, etc., etc. So they're all coming with quite a degree of agitation associated with this disorder. Heterogeneous presentation, the DSM has 6 specifiers to help with clarifying high and bidirectional comorbidity. So approximately 50% of individuals with insomnia will have a comorbid anxiety or depression. And even after a depressive episode is resolved, at least 40 to 50% of individuals will continue to experience insomnia. So pulling those apart therapeutically can be quite challenging. Why would we use psychology? The working group said sleep is by the brain, etc. I would suggest that insomnia is of the mind, that in many ways, if we can have a mental set that welcomes and accepts sleep, then we're well on the way to curing insomnia. Psychological therapy is multifactorial. It takes account of thoughts, feelings, behaviours, and their two-way interaction with sleep. It allows for the creation of a therapeutic alliance. In your usual session of 55 minutes or so, you can do in-depth skills building, manage expectations and setbacks, support other treatment processes. So if you as medical practitioners recommend dietary modification or weight loss, exercise, CPAP, postural adjustment, psychology can help with motivational interviewing techniques to support compliance with those recommendations. Minimal side effects. The Royal Australian College of GPs, as noted, recommends it as a first-line treatment. It's practical, so people have actual activities to do, and it's flexible. Less than 6 sessions is entirely possible. Certainly had response to insomnia in less than 6 sessions. Other relevant issues can be readily incorporated in treatment. There's an ongoing process of informed consent, so people are an active participant in their treatment. And it's modifiable across different presentations across the lifespan. Can be used for things like rebound insomnia if people coming off medications and are despondent about a return of insomnia. Psychological therapy can help. You can reassure your patients that they are unlikely to be asked to lie down, talk about their mother, cry, various other myths that do the rounds. But also that there's no requirement to remain with a treating practitioner. They can select other psychologists and find a good enough fit. And yes, apparently that is Freud's couch. All right, so one of the things that we'd start with for psychological therapy ideally is receiving a good referral. Dr. Srinivasan covered some of the aspects of physical exams, so I won't go into details, but having an idea of up-to-date medications, any results of tests and screeners, the Epworth scales were mentioned earlier, even the DAS-21 in one office compared to what they might do when they come here gives us a bit more information about other issues to keep an eye on. Any prior relevant medical history, diagnoses, interventions, and considerations of complexity. That can be comorbid disorders, epilepsy or seizure disorders, risk issues such as heavy vehicle operators or shift working, perimenopausal, pregnant, caring for young children, or significant psychological concerns such as highly maladaptive sleep cognitions. You may be in a position to provide some initial psychoeducation that might cover things like any sleep impacts of their current medication regime and what to expect in treatment. if you're able to, and you could remind patients that treatment is not a cure, it's personalized education and skills building. We're not trying to cure as much as teach this or reteach the skills of how to go to sleep. Where possible, we're trying to avoid magic bullet thinking. CBTI has been mentioned. BBTI, or brief behavioural therapy for insomnia, I have listed a link at the resources section where staff in office can do self-led education to provide some of the key aspects, which are sleep education, bedtime restriction therapy, stimulus control therapy, and relaxation techniques. That can be delivered by GPs and practice nurses in 4 to 5 sessions. I'll mostly be discussing cognitive behaviour therapy for insomnia. I'd like to thank my colleague Lucienne Shenfield, who looked over my shoulder on the detail here. And Terry covered the main aspects, so I won't labour the point. 6 to 8 sessions, and that homework is an essential element. It's not purely in-office discussions. Reasonably high efficacy, not 100%, but as I said, with minimal side effects, hopefully worth promoting to clients. Apologies for those who haven't had dinner for the sweets. It's supposed to be a pie chart with all the various aspects of CBTI, which you can read, and I'll go into more detail now. First off, assessment. This is one of the sleep diaries, one that we're currently using at psych sessions. Its method of use and explanations are on the other side, and most of you will either have access to or have seen a similar recording. Yes, it's subjective. To a large extent, that is the point. And we know from the research that people will tend to over-report wakefulness, under-report sleep. That's not inherently a problem, but if we get baseline and ongoing assessments, we've got at least some measure of progress and areas of concern. Questionnaires that we commonly use are the Epworth Sleepiness Scale, already mentioned, Sleep Condition Indicator, the ISI, the Insomnia Severity Index, Dysfunctional Beliefs and Attitudes About Sleep, the DBAS-16, Daytime Insomnia Symptom Scale. Very important to find out what the impacts are on daytime functioning. And of course, structured clinical interview. Usually we find multi-instrument assessments appropriate. Each clinician has a preference for the ones that they like to use. And as long as we're getting a reasonably comprehensive picture of the patient's concerns, then that's fine. On to formulation. As mentioned, differential diagnosis can be incredibly tricky. Being able to separate out comorbidities may not come with a first session, may come gradually through eliminating other possibilities, but at least a provisional diagnosis and identifying, prioritizing sleep interfering issues. Many people have a multitude of issues which are contributing to their sleep problems, and collaborating with them on where they want to put their energy and ideally where their sleep team, if they have one, is able to support is very important. Ongoing monitoring of the measures taken and their impact also needs to take account of the patient's ability to complete these and the quality that you're getting. Quantity may not be helpful if the quality is dropped off. So there's an ongoing liaison about what's a reasonable amount of monitoring to be engaging in. Now, a disclaimer, I have never shared this with a client. Terry mentioned the suprachiasmatic nucleus. I think it's handy to be able to describe that ideally the two processes, one, the process S of the longer one is awake, the stronger the need to sleep, and that's reduced by sleep intensity and duration. And the process C ideally are in sync. Many people will have a strong process S building fatigue, but in some way their process C, possibly through using screens at an inopportune time of day, has or feeding, fasting at an unusual time, has thrown one of the processes out. And the idea is we try and maximize sleep pressure in the evening, if they indeed want to go to sleep at night, and have maximum activation and alertness, reduce sleepiness first thing in the morning. I do use the SCN information to remind people about exposure to blue light and when that's best, that it's not just blue light's bad, but why that might actually impact directly through the optic nerve, the SCN, and hence all these other processes. There's some references in the notes if people wish. Yes, you've seen this one before, not so long ago. The way I use this is twofold. Demonstrate the wide range of normal for those who are fixed on, I need 8 hours, but also try to shift from the hours counting to, and that includes things like Fitbit, iPhone, and so on tracking, to focus on daytime functioning. That there is quite a wide range of hours that are considered normal. How are you going during your day? As Terry was saying, if you've got youngsters who are on 6 hours sleep, trying to point out that their functioning is going to be a lot less, their memory will be compromised, so they'll have to work harder at their homework. Sometimes that'll get through to adolescents and to young adults who feel that caffeine is a good sleep replacement. It also can reassure older adults who are worried that their sleep is declining terminally, that less and more fragmented sleep is actually common and doesn't necessarily mean that they're unable to get adequate sleep. I do use this one a little because it can be a handy way for people to describe their characteristic sleep patterns. You see I've annotated that slide. And yes, it's for a young adult, but it's a starting point for discussion. I may also throw in the idea of a standard pattern. Some of you will have probably seen that, where you've got 3 bad nights followed by 2 good nights. The tendency is for people to oversleep on their better nights and not stick to a regular waking time, but then catastrophize when the bad returns, as though it's all not worth it. So just normalizing that there are characteristic insomnia patterns, and we can roll with that too. Despite that image of catastrophic falling off cliff, I do use an analogy of gliding into sleep. Expert sleeping being to drift off. Some people, a number of people who I see for sleep problems, will describe using exhaustion and only going to sleep when they guarantee they will fall straight asleep, which I describe as crashing the plane. It is a way to get down to the ground, but not very sustainable for long-term health. Okay, so, yep, risk factors already alluded to. Neurodivergence wasn't mentioned. I'll briefly cover that. There is a very high coincidence of sleep problems in people identified as autistic and or attention deficit / hyperactivity disordered. Up to 80% of 2 to 5-year-olds diagnosed with autism actually have sleep problems. There seems to be some fairly solid research that related to melatonin secretion differences, possibly light sensitivity and hence avoidance, throwing out the melatonin, and social skills impairment. Those have all been implicated. Family history, also significant potential risk factor. With aging, I'll cover that in some detail later, but it's known, and with female, as risk factors. Lifestyle factors, I would include under that things like napping, substance use, irregular sleep, such as shift work and overseas travel, and under distress, things already mentioned. That can include chronic pain, anxiety, socioeconomic factors. Covered medication briefly, purely on the basis that as a psychologist, I get many people who are considering a sleeping pill as the quick, easy cure, and they either won't come to see me or they'll struggle to implement more difficult changes. They may also be unaware of the insomnia-inducing impact of other medication. I like to ensure that they have become fully informed on the risks and benefit of that. Yes, many people would love to be given an extra 30 minutes of total sleep and get to sleep 15 to 30 minutes earlier. But one of the psychological concerns is that the medication doesn't even seek to address the underlying causes of insomnia, and it can reinforce, use of medication can reinforce unhelpful beliefs and habits and impede what is effectively a normal, natural process. There are other concerns around medication, but for many of you, you'd be more than well aware of those. I will look at melatonin as a special case. I sometimes think of it as the Finnegan of the noughties. A 2023 American study found that 46% of American parents are giving their under 13-year-old children melatonin, 30% give it to their teens. One of the concerns, and I downloaded a vegan gummies picture, potency has been recorded as anywhere between 80 to 300% of what's labeled on the label. And we do know that more is not necessarily better. So there is a large unregulated market, and you'll probably have patients who are reporting this. Side effects do seem to be minimal, but they do exist. And the use in pediatric populations is effectively using people as beta testers. So yes, people are using it, and it certainly has genuine and indicated clinical use. I've listed a few there, but encouraging people to use more than just pill strategies, I think, is worthwhile. Okay, sleep hygiene's been mentioned. I suspect that many of you have dealt with that aspect. There are numerous handouts, and dare I say, many of them go into exhaustive detail. The Centres for Clinical Intervention from the WA government has 15 dot points. TMHC has 12. Ideally, these are presented not as rules that will guarantee sleep, but as suggestions that make sleep more likely. I certainly deal with a lot of people who say, I've tried everything, and they will list all of these as though any one of them was going to guarantee sleep. What they do is reduce the chance of sleep interfering habits rather than guarantee the outcome of sleep. So more agitation and stress, less sleep. You'll notice that I haven't listed get out of bed if unable to sleep. Now that is a recommendation under CBTI, but not under ACTI, or acceptance commitment therapy for insomnia, which I mentioned previously. So I'll deal with that in a little while. Bedtime restriction. As Terry mentioned, we're trying to increase sleep efficiency. That bed is associated with sleep, not with non-sleep related activity, particularly stress. The idea of limiting time in bed will in fact increase daytime fatigue. So having patients aware that we're going to perhaps increase your daytime fatigue, and understanding that when you go to sleep, you will sleep more effectively, hopefully builds their tolerance of what can be an uncomfortable process. Some people find it too aversive, and with older people, we may use sleep compression, where we will gradually reduce the time in bed, ideally down towards the amount of time that their sleep diary is recording. But for normal sleep restriction, we would be starting at the average sleep time recorded in their sleep diary, add 30 minutes, and then gradually increase the time in bed as sleep efficiency increases. This has the value of stimulus control. The bed is associated with sleep, but may not be appropriate for some conditions such as bipolar disorder, seizures, or where risk of daytime fatigue is going to be increased. So that would need to be dealt with greater caution, or again, as a team. Arousal reduction, most people are aware of these, so I won't belabor it. For those who aren't aware of autogenic training, sometimes used in mindfulness meditations, basically paying attention to different parts of the body and noticing them in detail. Focused mind to offset what many people report with insomnia, scattered and uncontrolled thoughts. So any habits of mind to train are an excellent starting point for insomnia reduction. And ideally, when the mind wanders into distress, finding safe and effective and repetitive habits which will offer a more effective alternative. Stimulus control, yep. Going to bed when sleepy and understanding the difference between sleepy and tired. not lying awake stressing. One recommendation being to get up after 15 minutes and return to bed only when tired. Bedroom for sleep or sex. Conversely, don't nap anywhere else but bed. Obviously, don't nap, as would happen with sleep hygiene. Don't nap more than 20 to 30 minutes, and not in the afternoon, or late afternoon, sorry. But if napping is going to happen, then ideally in bed. And I've had people who'd say, I can't nap in bed because I can't go to sleep, which is an excellent process of beginning insight on how their stimulus control has gone awry. Rise at a regular time, minimize daytime naps. Now, cognitive theory, the bit that CBTI adds to the BBTI, is to cognitively restructure sleep interfering thoughts and give strategies for reducing sleep impacting distress. So it breaks the link between sleep and distress, which we find patients coming with, by identifying, challenging, and or altering thoughts and beliefs that contribute to insomnia. So those can be anxiety, unrealistic expectations about sleep time and quality, worry about daytime fatigue. I imagine you, as I, have heard many people talk about the life-threatening aspects of sleep deprivation. They will have read some alarmist material on the webs, and I recall one patient who had counted how many minutes of life he had lost for each hour of lost sleep over the last 5 years. Not a recipe for getting more sleep. And we're trying to break the negative associations between the bedroom and wakefulness and distress. Now, I've talked about acceptance commitment therapy, and this is where I refer to the distressed mind conundrum. The Sleep Health Foundation, for instance, says if you try everything, I've added emphasis, and your sleep still doesn't get any better, then see your GP. And people will come and say, I've tried everything. And in essence, what they usually mean is, I have done everything rigorously. I have tried to control my insomnia. Unfortunately, in a number of cases, that doesn't deliver. For instance, another example, and I think this one was from the Sleep Health Foundation as well, set aside a worry time during the evening, then don't think about these things until the next day. I've got a part of my mind that says yes, but, and refuses to obey such an injunction, and subscribes more to what you resist persists. Hence, I raise the acceptance agenda, which is reducing the attempts to control your sleep, accepting you're awake, and not becoming distressed about the fact you're awake increases the chance that you will go to sleep. Sleepschool.org is the UK website of Guy Meadows. Dr. Guy Meadows expresses a lot of this information if people want to get into more detail. They actually have a program. So the control agenda, and this will work for some people, is to distract and dispute. So if my thoughts come up, I can assess them for realism, reliability, transferability, and hopefully develop the skills to park them. Or I can make space for distress and then focus on more values congruent action. Now, this is a level of detail that would be perhaps discussed with a psychologist, but if people ask, are there different ways of treating insomnia? Absolutely. There are these fundamentally cognitive behavioral approaches, but one moves more towards the control, one more towards acceptance. Okay, time's moving on. Therapy terminates ideally with some reduction in distress and increase in sleep, but certainly supporting ongoing skills usage through reinforcement, and ideally having the skills to prevent relapse. Very quickly, we've got delayed and advanced sleep phase. Delayed, obviously, hard to get to sleep and hard to rise. Advanced sleep phase, hard to stay awake and rising earlier than desired. For most people, wanting to sleep when it's dark. As mentioned, a lot of teenagers, up to 7%, will have a delayed sleep phase, which isn't just being a night owl, but does actually reflect an underlying disorder. Depression is an extremely common comorbidity with various sleep disorders, but social anxiety and avoidance will often masquerade as delayed sleep phase, where people just prefer not to be around others and get their more soothing alive time at night, and they may tend towards a nocturnal habit. 64% of people with delayed sleep phase also have depression. As many as 75% of adults diagnosed with ADHD in childhood also have circadian rhythm delays. Lots of opportunity to confound what looks like just insomnia. For treatment, chronotherapy is the standard, where we would delay sleep time at anything between half an hour to 3 hours a day, depending on the client and their situation, until they go fully around the clock and achieve a desired sleep-wake time, and then use in bright light, sunlight or artificial bright light on waking, and to continue once treatment's concluded to avoid relapse. This is not popular, up to 50% treatment resistance. So navigating through clients' will to do this is a significant contribution that the therapist can make. Now, this is a client who presents with some complicating challenges. The downwards arrow is a evening melatonin taken hour or so before bed. PRN, a Z group sedative, 2 sedatives, unsure which one she's taking. She's in her 70s from a long non-English speaking background. Highly fragmented sleep, and reports difficulty remaining awake in the evening and difficulty remaining asleep in the morning. You see wake time often well before 5. So encouraging this person to actually not take melatonin long before sleep, but to delay it to increase sleep duration and the chance of rising later, while they also pull their sleep towards the time they like. So they are looking at, instead of turning the telly right down in the evening, keeping the light brighter until about an hour before bed. There is suggestion that people in later life have decreased optical capacity, so incrementally less light reaches the brain, and night appears to arrive earlier. One suggestion around advanced sleep phase disorder. So melatonin is indicated here, and the bright light reflecting daytime light to ensure that they delay sleep until a time that works better for them, rather than battle through and find that they're out of phase. There's the opportunity perhaps for fast release melatonin during one of those awake periods, but for now we're continuing to use the slow release to see whether we can get a shift in the preferred direction. Okay, the sleep team currently at psych sessions, and we do both telehealth and in-person work, is listed there. Contact through the reception. I've also listed, rather than going through in detail, a number of resources. The Sleep Association mentioned actually has an education portal that you may want to pursue in your own time. And there's a few, I won't call them quick and dirty. There are some peer researched articles that in a number of pages go into the depth you might need to refresh the learning that you did in med school or similar, neurobiology and sleep disorders primarily. There is an ongoing study, as far as I know, still running at the University, Flinders Uni, still recruiting. The point being made, and I've listed it there are very few clinicians in Australia that have the skills and expertise in CBTI delivery. So even with that small number that Terry mentioned of people who do get to treatment, there is a limited number of people. Hopefully places like the Sleep Foundation are adding education and supporting people to get good quality treatment early in the process of their insomnia. Thanks, and back to you, Michaela.
Perfect. Thank you so much, David. That was highly informative. We will jump back to the questions in the Q&A now. We've got two already, and I think, Terry, the first one is probably for you. And asks, do you approve of any pharmacy-provided sleep studies, and can you recommend which type or brand of study would be considered adequate and accurate for diagnosis?
Oh, right. That's a great question and might be a bit tricky as well at the same time. But the way I would address it is it all boils down to the patient in front of you, the individual right in front of you. I mean, I do look at the report. It all depends on the so-called pre-test probability. They do have their role to play in healthcare setting. They do give you some diagnostic information. They give you some clues, etc. Say, for example, if a patient in front of you, I mean, it's pretty clear cut that they've got all the high risk factors and very clear history, and they had a level 3, a so-called level 3, in other words, a level 3 sleep study. In other words, they get it through a chemist, and there's no recording of the brainwave activities or the EEG. It's simply just a measurement of the deprivation of oxygen desaturation, the limitation of the airflow, etc. It gives you some ideas with a compatible history. Sometimes I would accept it. That's fine. But the problem is when it comes to the sort of less clear cut. And I think with a lot of my GP colleagues and other physicians alike, the practice of medicine is not always just, chalk and cheese and as clear cut. So, with the right history, with the right patient, it may be helpful, but very often I would have a much lower threshold to actually do a proper sleep assessment, get to know them, get to know the history, go through the clinical problems again, knowing the background medical history. And if necessary, I will probably do a proper diagnostic sleep study, whether it's level 2, which is a home diagnostic sleep study with all the attachments and assess and all the signal acquisition provided by the technicians, and then they stay at home and sleep, and then they return the equipment, or whether it's going to be an in-lab sleep study when it's deemed appropriate. So I think that's probably would provide you with a better assessment and accurate analysis of the sleep during the night. When it comes to different brand, I think that the person who's asking this question, I think Robina were asking about whether it's the brand of the testing equipment. I don't think it matters that much so long as it provides you with the right diagnostic information. The brand themselves obviously doesn't matter. Same applies with the CPAP equipment as well. The brand is the least of the worries. I mean, CPAP, treatment itself is a proud Australian invention. All right, okay, it was actually invented and developed in Australia. It's a pump, okay? It's a continuous positive airway pressure device. The brand itself doesn't matter that much anymore. The technology is actually not very advanced. There's more sensitive algorithms these days, and the machines are just getting better and better. There's a multitude of different brands available on the market. I don't think it matters that much, so long as the right setting for the right patient.
Thank you, Terry. We've got time for this second question now, and I think that could be answered by either of you, so feel free to jump in. It says, could you please comment on the concept of biphasic sleep? There seems to be a lot around in the popular press, and I'm unsure how to answer patients about this.
I can have a crack at that if you like, Michaela. Yeah, I think there is a whole range of sleep, and there are cultural aspects around how we sleep, who we sleep with, etc. That I talk about century points with clients that traditionally, we had rousings during the night, which meant we could check our safety, check the well-being of the tribe, stoke the fires. So a century point is a natural habit, and we know that we have, through that sleep architecture, rousing points. And if you use one for well-being, and if you define well-being as doing some 16th century important documentation and or checking how your kids are going, not a problem. learning what's necessary and what isn't can be part of the treatment. That I think simple biphasic, again, is a popular oversimplification, but we can break sleep into a whole different patterns. And what I do check for is, how's your daytime functioning?
Thank you, David. I think we have time for this one last question in the chat. And that's for you as well, David. It says, if tinnitus disturbs sleep, could CBTI be helpful?
Briefly, yes, because for most people, pain and distress, and that includes the distress associated with tinnitus, can be reduced with CBTI or ACT-I. So the idea is, yes, you have a situation. What does your mind do as you notice this? I'm working with somebody who, after a motor vehicle accident, has quite severe tinnitus, but also has very dysfunctional sleep beliefs. For instance, don't take me away from my midnight sleep onset time, or I'll never sleep. So teasing those apart and reducing his distress is part of the therapeutic goal, so that the perception of that intrusive sound isn't as intense and difficult. And certainly for people with neurodivergence, I've certainly worked with people where we can lower their overall distress levels. The intrusiveness of that experience isn't so severe. It doesn't remove it, but it reduces the aggravation, the distress felt with it. I don't know how long that person's been living with that, but I would say yes, it would be worth exploring with them to see whether we can reduce their distress around that oral experience.
Thank you. I think it's just about time that we wrap things up. So thank you again, everybody, for attending tonight, and a special thank you to David and Terry for your wonderful presentations this evening. The next sleep webinar in this series is scheduled for 7 p.m. on Tuesday, the 19th of March. So please save the date in your calendars. That will be presented by sleep and respiratory physicians Dr. Marianne Turner and Dr. Daniel Wang, and they're going to be presenting on sleep apnea and comorbid insomnia and sleep apnea. The evaluation surveys for tonight's event will be sent out shortly, so please fill in the post-event evaluation surveys so that CHN can email you out your certificate of attendance for this evening. And please feel free to jump on and self-report 1.5 hours of educational activities on your CPD home. Resources, presentation slides, and YouTube recordings will be emailed to participants who complete the post-survey evaluation. So make sure you jump on and do them once they're sent out to you. And that's it for tonight, everybody. Thanks for coming.
Thank you, everyone.